Good evening. I'm Jeff Locke. I'm one of the owners of Five Star Orthodontic Lab and Supply. Really excited to have you guys here tonight and excited to have Dr. Rondeau talking about early orthodontic treatment and specifically airway. I know you guys are going to get a lot of education about this. We've been supporting Brock for at least 15 years, maybe more, throughout the United States. And one of the things that we've been really successful with helping him at is support, especially after these meetings. We have a couple of top-notch clinical consultants that know Dr. Rondeau's protocols front to back, and that's what they do all day, every day, is stay on the phone with doctors and help them with case selection, appliance selection, finishing techniques, you name it. We're kind of there as an extension of your orthodontic practice. So we're really excited to get this on the road. And I want to introduce one of our clinical consultants, Andrew, and he's going to say a few words, and then we'll hand it over to Dr. Rondeau and get the evening started. So thanks again for being here.
Yeah, thanks, Jeff. Hi, everybody. My name's Andrew. I'm one of the clinical consultants at Five Star. And yeah, just to echo what Jeff said, basically what our role is to help make you feel comfortable on starting cases when you get back into your office after the courses. So pretty much all I do all day is talk to doctors on the phone. They'll send cases into us and help decide if it's an easy case to treat when you're getting started. If so, what appliance might be a good option? Mid-treatment, you're running into issue that you didn't think about. What do I do next? And that's the kind of questions that we field and that we help with. So like our job is basically to make sure that you feel as comfortable as possible treating cases once you get into the office after the courses. So you have a support system in place for once the course is over, when you start treating cases in your practice, and that's what we're here for. So very happy to meet all of you guys, and I guess I will hand it over to Brock and we'll get started on the lecture.
Great. Okay, everybody, I'm glad to be here. Now, here's the first slide, right?
Yep, hang on. Let me
I gotta
get
put the first slide up.
up.
There's supposed to be a picture of me there, you know, like, I know they're dying to see my picture, you know.
Just a moment.
So anyway, welcome, everybody. I'm very happy that you joined in tonight. And those of you who didn't join in, we can make available to you a video of it's an hour presentation. We're going to try and keep it right to an hour. And then afterwards, we're going to have questions. You can send your questions in to Andrew, and I'll do my best to answer them for you. Hats off to Five Star. We've been definitely working together more than 15 years, Jeff. The president, Bobby, there can't be with us tonight, but you're with us. And Andrew has been unbelievable. As Andrew says, he answers all the questions when I mix them up in the course. So I mix them up and Andrew straightens them out. So that's good. But seriously, everybody, I think you're going to love orthodontics. I advise you to keep your general practice and just add ortho, because 75% of children in your practice have a malocclusion. So it's very easy to do it. Now, you have to check with your local orthodontist to see if they're doing early orthodontic treatment. More and more are doing it, but not all of them. So if you happen to be in an area where there's no orthodontist doing early treatment for children, there's no competition, and your patients want to go to you anyway. They don't want to go to a stranger. They want to stay with you. So you're going to have an opportunity to really help a lot of children and also maybe increase your income a little bit. So that's what you're going to want to do. When do we start? I mean, sometimes I'll start children at age 5. We'll use fixed appliances because they're not as good cooperating at 5. And that's what we do. But we can use fixed appliances. I'm going to show you some fixed appliances tonight. I'm going to show you removable appliances. The first thing I should show you is you have to have a proper size arch. The arch on the bottom is nice and broad, and the arch on the top is V-shaped. And what happened was we used a functional appliance to expand that arch and make room for all the teeth. The arch above, the cuspids might have come out like fangs. And plus, you wouldn't have had a broad smile. Everybody wants a broad smile, and everybody wants all the teeth. So we teach no extractions, no surgery, do everything with functional appliances, and then finish the case with braces in many cases. So the early treatment philosophy started in Europe. And I went and heard courses done by European orthodontists and general dentists and learned that early treatment was the way to go. And that's what 5-Star does so well. I've had to make several appliances for me over the years, and they all fit beautifully. And the course participants that have taken their courses have loved their lab and stick with them. And plus, they're the only ones that know all the appliances they use. You send to another lab, they won't know what appliances we're using, and that's not good for you or good for the patient. So functional philosophy is if you got crooked teeth, you don't extract. If you got crooked teeth, use functional appliances to develop the arches and do no extractions. I can tell you that's music to the ears of the mothers. They don't want to extract teeth. They don't want narrow smiles. They want beautiful broad smiles with straight teeth. That's what everybody wants. In North America, I find that many clinicians were trained to do fixed braces, permanent dentition. So you have to talk to your local orthodontist and find out if that's his philosophy. That's his philosophy. You've got to treat your children early, and maybe you can avoid fixed braces. So here's how Jeff mentioned the airway. I've been teaching how to create a proper airway for years and years and years. And now it seems like every magazine you pick up is how to fix the airway. Well, number one is arch development. Because when you expand the upper arch, you make more room for the nasal airway to open up. The nasal airway expands and the patient becomes a nasal breather instead of a mouth breather. Mouth breathing is your enemy. You got to look out for mouth breathers and you got to fix them. If your mandible is too far back, you got to bring it forward, and that opens the pharyngeal airway. The other thing that people miss is if you're overclosed vertically, you have to build up the posterior teeth in the back and open up the vertical. Those are how you create a beautiful airway and a healthy child. Look at that picture. Look at the profile. So we brought her jaw forward, but we also increased her vertical dimension. The thing I don't like about Invisalign is Invisalign opens the bite by intruding the teeth. If you opened her bite and she had a deep overbite of about 7 millimeters, by intruding her teeth, her jaw would stay like that. But by moving her jaw forward and erupting the back teeth, that's what she looks like. Fantastic change. So here's a narrow airway in the diagram on the left, and here's a wider airway in the diagram on the right. And you can see the lower jaw had a slight overjet in the beginning picture, and then a kind of an anterior crossbite in the other picture. But that's what we would do if you had a snoring appliance. We would bring the jaw slightly more forward. We don't do that if we're using functional appliance. We go right to end to end. So using the oral appliance moves the lower jaw forward, opens the pharyngeal airway, which I just showed you. Snoring appliance, I have this diagram in my office. I show the patients because we do snoring and sleep apnea too. So the lower jaw falls back, as you can see the tongue blocking the airway. And then when you put the appliance in, the snoring appliance, the jaw goes forward and the air goes right into the lungs. Well, functional appliances work the same way. So I believe that early orthodontic treatment will eventually prevent sleep apnea in the future. So my practice now is limited to the treatment of orthodontics, temporomandibular joint dysfunction, and snoring sleep apnea. I would advise you all to start with early treatment for children because it's the easiest. I have obviously a course that's 4 sessions, 8 days. At the end of that time, I think you can do orthodontics. You can do the simple cases. So a twin block appliance, we'll show you in a little while, brought that lower jaw forward. And you can see her profile looks much better. But what I didn't realize when I did this 30 years ago is that when you bring the jaw forward, you also open the airway. So you help prevent snoring sleep apnea later on in life, and even at the present time, because children snore too. And you also help the temporomandibular joint. You want to prevent temporomandibular joint dysfunction. Okay, and you can do it if you move that lower jaw forward. Look at this guy. I mean, he looks so good on the right. He didn't look that good on the left. I mean, if he goes through life looking like he did on the left, he's got poor self-esteem. He's not treated the same. He's got a weak chin. They think maybe he's weak. Who knows? He looks fantastic forward. and it changed him completely. He improved his self-esteem. It just works. So there's a lot of articles in the literature which we can give you that shows functional appliances bringing the jaw forward opens the pharyngeal airway. You got to realize you want an open pharyngeal airway. You want to be able to breathe through your nose and not your mouth. There's another case. Look at this little girl. I mean, the photo on the left, it looks like she's older. The photo on the right, her jaw's forward. She's actually 9 months older. So she's 9 months really older, but she looks younger. So that's what you want to do. So we talk a little bit about the TMJ in the course. Many of us were trained to put the jaw up and back, but that was wrong because the nerves and blood vessels are there. So if you look at the diagram where we're pointing to the nerves and blood vessels behind the head of the condyle, you certainly don't want to put the condyle back there. And you can see right behind that is the ear. And you can see the disc that slipped in front. So now every time that patient opens, they'll go onto the disc. So if you hear a click, that means the condyle is too far back, jamming into the nerves and blood vessels and causing pain. And so you want to fix it. So if the patient comes in with a retrognathic mandible, you can assume that, and they're clicking, you can assume they look like the diagram on the left. If you move the jaw forward and the disc is recaptured and you don't click anymore, you can assume that the functional appliance moved the jaw to the correct position, and you'd be correct. So advancing the mandible prevents TMJ. Let's look at Joshua. Okay, cute guy, narrow arch. The first thing you make a note of is if your arch is narrow and there's no room for the lateral incisors, you need to expand, period. He had no room for the laterals on the upper lower, so we had to use an appliance to fix them. And so this is a good trick. The cotton roll is 37 millimeters. If you put the cotton roll between the molars like this, in permanent dentition, you'll have room for all the teeth. So we need to do this in children and just see how wide it is. But if you don't want to figure measurements, then just make room for the lateral incisors, upper and lower. You can see if there's no room, if the cotton roll on the left doesn't fit, you find out that the laterals are up on the lingual. So why would you wait? If you have a child that's 7 years old or 8 years old, and there's no room you don't have any, you've got a narrow constricted arch, and you got maybe 25 millimeters from molar to molar, you better get in there and expand that arch, or the laterals are going to come in on the palate. Why would you wait and have that happen? So there's a neat little appliance that 5-Star makes. It's a simple little appliance we recommend for using for 8-year-old girls. Start with 8-year-old girls because they're so cooperative, they'll do everything you're told, they're smart. Unfortunately, boys are not as smart at 8, but of course we catch up later, as you know. But at age 8, a boy would get a fixed appliance, a girl would get a removable appliance. We do both. It's got one midline screw, which you turn twice a week. Take the appliance out, turn the screw, put it back in. They adjust it twice a week. They come with all kinds of different colors. So 5-Star have these color charts that you can get from them. And of course, this is an older one I got from them, but they've got newer ones now, and they can pick a color. If they pick a color, they love it. It's their appliance that they pick the color. So you wear it all the time, except you take it out to clean it, to active sports, adjust it twice a week, every Wednesday and Saturday. When you adjust it like that, you get 2 millimeters expansion a month, 2 millimeters a month. So there's the lower one, which is much smaller, easy to adjust. See, on the right-hand side, I've got the key in there. There's an arrow telling you how to turn the key. You turn it all the way towards the arrow and then take it out and put it back in the mouth. Easy, easy, easy. Your team can do this. You don't have to do this. Your staff can handle this. One thing I really like about ortho is that the staff do all the work. I'm very proud of the fact they call me Dr. Delegator because I delegate. They go to bed at 9 o'clock at night because they're so tired, and I go till at least 11, and I'm not tired because they do a lot of the work, but they love it. They love helping patients. They love what we do, and we're a great team. And And when they come to work for me, they're there for life. It's a career. Some of the staff have been with me 25 years. And so I'm very, very happy because once you start training them, you want them to stay. You don't want them to leave. And they motivate and educate the patients. So there's a narrow arch, and you can see on the right-hand side, we've expanded the arches, upper and lower, and now there's room for the lateral incisors. And so we started out with an intermolar width of 26 millimeters, and normal is 36 to 39, and we expanded 7, so that would be 33. We expanded them 7 millimeters, went from 26 millimeters to 33 millimeters. So he will develop more on his own, like we finished him when he was 10. And so he will still develop another 3 or 4 millimeters on his own. But now he never had to have extractions. He never had to have, he didn't even have to have braces at the end because his malocclusion was pretty well fixed. And his mother lived a long way away. And she said, I don't need it to come back because you've done most of the work. The appliances do most of the work. You have to charge adequately for these appliances because sometimes you do 80% of the work. You're going to see some of these cases I'm going to show you, do 80% of the treatment when they're actively growing. And so you should be getting, $2,500, $3,500 for these cases. And the mother is very happy to do it because ortho is $6,500 and $7,500. If they can avoid that cost, they definitely want to do it. Plus, the children are more cooperative at 8 than they will be at 13. The toughest patients, of course, are the 15-year-old boys who don't even want treatment, right? Look at the nice arch we've created, which makes more room for the tongue. People can speak better. There we have no room for the laterals, room for the laterals. Same thing. And lots of room there for a lateral incisor on the right-hand side. There's the lateral, lots of room. So for that case, we charge $2,500 for upper and lower Schwartz appliances, which 5-star make. They probably charge about, I would guess, Andrew, you're not on there, you can't speak to me, but you can tell us later, Andrew, what the fee is for the upper and lower Schwartz, but it's a lot less than $2,500, I can tell you that. And the records are $500, and the appliances fit beautifully. So there, he's finished. He finished like this. He had a little bit of a deep overbite, but no jaw problems. So the mother said, I'm not going to do any more. He looked pretty good. So there he is after phase 1. Now, I've written a book. If you sign up for the course, you get that $169 book for free. Isn't that a fantastic deal? Anyway, it's got 19 cases of functional appliances throughout, all the appliances we use. So I would highly recommend you get the book and read it. It'll make it a lot easier for you. So here I've got 2 patients, and I'm showing them a case similar to theirs in the book. So if you can show a patient that's similar to their problem of a patient you successfully treated in the book, and you can just say, I'm taking a course with this gray-haired guy in the back of the book, that's just as good as you doing it yourself. So it really works. And I can guarantee you, so Jeff, someday we got to go to Hawaii and play that hole. Now, if we're playing that hole, okay, I would either be in the grass or the ditch in front of the green, never able to find the ball, and Jeff would be on the green. And so that's the problem. That's one of the reasons I don't like him, because he always outshines me on the golf course. But he's a great guy. And I'm just kidding. I love to play with Jeff. Okay, everybody always wants a beautiful broad smile. Okay, so number 1, remember, all mothers don't want extractions. They want arches developed so there's no extractions. They also want arches developed so you got a beautiful broad smile. Like Julie Roberts has got a gorgeous smile. Here's a magazine article I found, and it showed that one's got a broad smile and one's got a weak smile. I don't know if William had extractions, but I just know he's got dark corners at the side of his mouth. He could have maybe, if he'd gone to someone who does functional appliances early on, he might have had that arch developed and he'd have a better smile. So anyway, we want to make sure our patients have the greatest smile we can give them. So there's another picture of William and Kate. And here's a patient who's 15 years old who was going to get married. and she didn't like her smile, and she had some crooked teeth. So I said, come on in. And this is a Hyrex appliance. This is a banded Hyrex, which they make very successfully. You put bands on the first molars, you put mesial rests on the first bicuspids with flowable composite, turn it twice a week, and in 5 months, you have 10 millimeter expansion. Now you've got room for those teeth, and you get them all in without extracting. They also have an appliance like this called a fixed lower expander. The neat thing is this, you don't have to turn it at all. It's got a spring that just expands by itself, and you get about 1 millimeter a month with that. So we can show you how to use all these appliances in the course. And what's really nice, you put it in, it works by itself. You don't have to do anything. You get 1 millimeter a month. When you get what you want, you can pinch that coil in the middle and it won't expand anymore. We'll show you how to do that. So there we are. We actually got 6 millimeters with that appliance, and we had to put another Schwartz appliance in to get another 4. But you'll see in a minute what a great smile we got after 6 months. I mean, she even decided that blondes had more fun and decided to go blonde. And I guess with that smile, she is going to have more fun. But look at the arch. Now that's after expanding with a Hyrex, 10 millimeters, and also putting braces on. Look at that beautiful broad smile. Look at that beautiful arch. Look at the lower arch. Look how crowded that cuspid was on the left-hand side. And look how it's lined up and how beautiful that arch is. So you got a constricted arch, you expand, you got a broad arch. You got a protruded tongue. Look at how the tongue is back and the tongue is forward, so easier to speak. Possible sleep apnea when the tongue falls back and blocks the airway. Tongue forward, breathe better. Maybe never get sleep apnea when she gets older and puts on weight. So you're doing a lot for these patients. Look at the constricted arch. Look at the broad arch. And this is just using functional appliances. At the very end, just putting braces on to straighten the teeth for maybe 6 months. All the work is done with those functional appliances. There are many orthodontists using functionals, and there's many general dentists using functionals, but there's a lot not. And I can tell you, if you try to do this case with Invisalign, you are not going to get these results. You cannot get these results with Invisalign. You can't get the expansion of the arches. Now we're doing Invisalign and clear aligners, and 5 Star also make aligners for you, and they work for minor cases, but not these big cases. You need the functional appliance first, and then you could use aligners. So tell the patient, yes, we'll give you a proper size arch with functional appliances, and then you can have braces or aligners, whatever you want. Look at that smile. I mean, look at those eyes. Boy, does she know she's good looking and she's a sweetheart, and does she have a lot of confidence? That's confidence. I mean, she's got the smile that everybody wants. Okay, so I would like in the course to show you simple cases, as Jeff and Andrew mentioned, mixed dentition, functional appliances, no extraction by expand arches. I mean, you're going to have so many of these patients in your office, you won't believe it. This guy had bicuspid extraction. He doesn't look that good. Came to my office with snoring and sleep apnea problems. Had to make an appliance. If he hadn't had the extractions and had his jaw brought forward a little bit, maybe he could have not had sleep apnea. Move that jaw forward. Remember I showed you she looked so good before? Here's a little guy now that doesn't cooperate. He's 7 years old. You're not going to use a functional appliance on him, okay? So he's got no room for his laterals. You can see there's no room for the upper laterals, no room for the lower laterals. They're coming in crooked. You need to expand his arch. Look at that small little lateral in the left-hand photo. You need to expand that arch. There's no way that that's 37 millimeters across, but remember, 37 millimeters for adults. But if you got 25 millimeters across, you're never going to get to 36. So develop the arch. Same thing in the lower. Develop the arch. We're going to use a transverse transforce appliance. Now, 5 Star have this one, and they have other ones that will expand. And so we can talk about in the course which ones are the best. I like these for younger patients. Older patients, I think they have better appliances, like that one with the spring I showed you is a little better for older patients, but we'll tell you. So we put that in, very comfortable. It's very small, right? Just a small little appliance. On the bottom, it's got that spring. This actually works better than that one. But we use one on the bottom and one on the top, but they're both small. They don't take up much room. They don't affect the speech, and just let them work. Okay, and pretty soon, you can see the diagram on the right, you got room for the centrals and laterals. Just stop then. Deactivate the appliance. Okay, pinch that coil in the middle with the bird beak plier, and it deactivates it. And once you expand, you have to hold for 6 months. Expand, hold for 6 months. So here's the appliance going in, and you can see it's open 4 millimeters. And then after a few months, it's open 9 millimeters after 5 months, and you're done. How easy? You don't have to do anything. You understand? All you have to do is make a right diagnosis. Scan the upper arch with your scanner, or take an impression, pour it up. Fit the bands on your molars. We'll show you how to do that. Send it to 5-star, and they send you back the appliance. You cement it in, and you wouldn't have to see the patient every couple of months only. And in 5 months, it's done. And then leave it in for 6 months. You don't have to see the patient, just leave it in. See them every 2 or 3 months. So these are very cost effective and do a fantastic job. And you didn't do anything. Now the bands came off, it's a little bit of bleeding going on there, but boy, look at that arch. And the lower arch had that other expander in the bottom, fixed expander. Look at that arch. I mean, this is the way to do ortho. Expanders removed. Look, the front teeth are beautiful. Uppers and lowers, all straight. No braces, just strictly expansion, make room for the teeth, and they come in. So again, start like that. Finish phase 1 like that. The laterals came in beautifully. Remember, no room for the centrals and laterals, expand. How much you expand? Till there's room, then you stop. Then hold for 6 months. That's it. That's it. Imagine you had 50 of these patients. You would be amazed how many of these, you got 75% of the children in your practice. Most of them have this problem. They got a constricted upper arch and or a lower arch. And remember, as I mentioned, you convert a mouth breather to a nasal breather, which from a health standpoint is unbelievable. I mean, I'm going to show you a little on airways tonight, but the next session, I'm going to show you more in airways. Okay, so the upper and lower fixed expanders, I charge $2,500, records $500. You could easily charge $3,000 or $3,500 for that today, and the mother would pay every nickel. You know what I like about ortho too? There's no selling. Probably many of you have children, and you know you do anything for those children. You go to someone that says, we need to develop these arches to make room for all the teeth. We don't have to extract. You don't say anything but how much, when do we start? And then they don't question you. They want what's best for their kids, and they don't question you. They just said, when do we start? And I love that. They want health, they want treatment, and you don't have to promote it. Not like trying to get them to go for a $4,000 implant, believe me. That's a little different situation. I love ortho because there's no selling, it's just presenting. So there's the upper arch after phase 1. There's the teeth. I guess that's almost phase 2. Anyway, so I think we did put brace on for a short period of time. So here's the course. You can look online, rondoseminars.com. If you need to call anybody, you call Lee at rondoseminars.com. And so we're starting in Dallas in October. And we go October, December, February, April. The cost of the course is $12.95 each session. But we've decided that if you sign up right away, it's going to be last year's price, which is $10.95. So you'll save $800. There's Chicago. Chicago's September, November, January, March. So let's say you start in Chicago and you couldn't make the second session in November. Well, you might be able to go to the second session, in Dallas. Second session in Dallas is December. So it's exactly the same course. And each course has a course manual of about 250 pages. So there's colored pictures of cases in the manual, similar to the ones we show. We really want you to do this. So there it is. We're offering the course are $10.95 instead of $12.95. Okay. I think it's within a month. And you can bring 2 staff to session 1 at no charge. So pick 2 of your favorite staff, at least maybe a hygienist and maybe a dental assistant, and bring them to the course and see what they think. And see if they like our treatment philosophy. See if they'd like that added to your practice. See if they'd like you to treat their own children who have these problems. Remember, 75% of the children in your practice have a problem. Okay. So let's talk about the detrimental effects of airway obstruction in children. Okay. So I had a teacher yesterday in my practice. So I said, how are things going in the teaching business? I understand that kids are more difficult to handle these days. She said, you won't believe it. I'm having a lot of trouble teaching because I have learning difficulty. Some of the kids have learning difficulties. Some have lack of focus, and some are hyperactive. I said, that's because they have attention deficit disorder. That's very common. All those things are common. And it's undiagnosed in many cases. And I'll talk a little bit about that. But she said, that's unbelievable. I said, are they mouth breathing? She thinks a minute. She says, yes, they're all mouth breathing. I said, that's the problem. So you got to find out if they got a narrow jaw and send them to someone who can develop it. Or you got to find out if there's tonsils or adenoids and get them referred to an ear, nose, and throat specialist and get them out. But if you don't do something, this is just going to continue. They're going to do poorly in school. They probably won't make university because their marks are so poor. Their whole life is being affected because they're mouth breathing. You got an airway obstruction and nobody's diagnosing it. You and I both know we went to dental school. We learned nothing about this. We never looked at a tonsil. We never looked at an adenoid. We didn't worry about that. We only worried about the teeth. Well, guess what? The world's changing quickly. I think parents are going to find dentists that are concerned with more than just teeth, especially when it comes to their kids. So I asked her, is she a mouth breather? And she said, yeah, they're mouth breathers. Does that guy look healthy to you? Of course not. Look, he's got a mouth. Look, his mouth open. Breathe through his mouth. Look at his upper lip going up. So what's really interesting is it retards normal growth. If you look at the bottom, it says no stage 3 sleep, no growth hormones. If that child does not get to the deep stage of sleep, no growth hormones are secreted. Do you think that affects that little guy their whole life? I guess it does. And it's all because of your mouth breathing. You have to find out what's going on. You want to be busy in your practice? Help those patients. You help that patient. What do you think the mother's going to do? I wish I could find his second slide because he looks so different in a year. His father didn't recognize him. He didn't recognize the original picture. He said, I can't believe he looked like that. I said, he looked like that. And now he's putting on weight. He's growing. He's got growth hormones. He's a happy guy. He's a nasal breather. He looks so much better. So look at this. Obstructive sleep apnea, obstructed airway can cause sleep apnea, where they stop breathing at night. Problems paying attention in school, which is happening to that school teacher's students, often tired, behavioral problems, and it's ADHD. So remember, what happens is when they lie on their back, the tongue blocks their airway. And that happens a lot in class 2 cases. But you got to look for enlarged tonsils, enlarged adenoids, and you got to look for snoring sleep apnea. It's not normal for a child to snore. The child snores, that's not something to be taken for granted. That's a serious situation. And they need to be checked for sleep apnea. So what I do is I tell the mother, you go in and videotape that guy when he's asleep. You videotape him and you take that videotape to the ear, nose, and throat specialist, and you tell him, I want these tonsils and adenoids out because my son can't sleep. And look at him, he's struggling to breathe all night. He's choking when he's trying to sleep. Okay, we give you lots of information on this in session 3, so you can go talk intelligently to the ENT. Okay, so these are all things that can happen to kids with sleep apnea. The interesting thing is we've just had a hygienist come to our office who does myofunctional therapy, and she's teaching us all about tongue ties. And it's absolutely unbelievable the number of problems that tongue ties cause in children. I mean, we got a page of them. So she's going to be presenting again to my team at lunchtime, all about tongue ties and how important it is. And so I just can't believe what problems this is causing. And what they have to do if you want to check tongue ties, you try to have them open as wide as they can, like the photo on the left, and then actually the photo on the right. Then you have them put their tip of the tongue on the size of a papilla and see how much they can open. If they can't open half, they're tongue tied. So you got that? They could open 50 millimeters incisor to incisor. And then they put the tip of the tongue on the inside of the papilla, and they can't open more than half. They're tongue tied and they need the operation. So I'll give you a little more information next time after I get some of her slides and get her lecture, because she knows a lot about this. That's what she does in her practice, that she specializes in this. So isn't that a beautiful photo? Look at how the slide on the left, she's got no self-esteem. She's looking down. And the one on the right, she looks fantastic. Great self-esteem. We talked about the airway, showed him. That little guy doesn't look healthy, does it? You're going to put brace on that guy? I hope not. He needs to have his malocclusion fixed. He needs to have his airway fixed before you do anything. So the medical profession treat sleep apnea. No, they don't sleep apnea. They treat ADHD, attention deficit disorder. They treat it with drugs, Adderall, Concerta, Ritalin, and these drugs can cause reduced height and weight, cardiovascular effects, tics, substance abuse, all kinds of problems. And they're giving these kids all these central nervous system stimulants. Can you believe giving them a stimulant? There's some guy that's stimulated already. What do? We eliminate the cause of the obstruction. Eliminate the airway obstruction. Is it adenoids? Is it tonsils? Is it allergies? Is it deviated septum? What is it? You don't have to figure it out. You send the ENT specialist and say, check him out. Check his nose, check his tonsils, check his adenoids. I want to know what's going on. And then give the patient a new drug. It's called oxygen. It's probably the best gift you can ever give anybody is oxygen. You know you don't live long without it. And these kids are being deprived of oxygen. It's affecting their whole life. And our profession doesn't even cover it in dental school. And I would suggest, from talking to many, many orthodontists, it might be changing, that many, many orthodontists are also not getting any training in this. So we need to pick up the ball and we need to help our patients. You need to help your patients get healthy. Our mission statement is the pathway to health starts here. You have to decide what kind of a dentist you want to be the rest of your life. Don't give up your practice. Keep doing all the things you're doing, the great things you're doing, but add this to your practice. Add this to your practice. Get your team involved. Train them. Learn some new stuff. Start helping these kids get healthier. And I can promise you, you're going to recession-proof your practice. This will set you apart. You'll be different from all the other clinicians that never learned this. So that's my advice. Okay, so adenoids has to be picked up in a cephalometric x-ray. You see the airway down at the bottom by the angle of the mandible is about 10 millimeters wide, so that black area. And then the top, the adenoids are blocking the airway at the top. Look at the tonsils. How is that patient going to breathe? Those two huge meatballs at the back of his throat. And remember, I'm pushing his tongue down. Remember what kind of a small airway he would have if you didn't push his tongue down. So start checking for tonsils, start checking for mouth breathing. And look, I'd love you to do this, but if you don't do it, please find someone in your area that can help these kids. But why wouldn't you do it? Why would you send out all kinds of cases to orthodontists or general dentists when you can learn to do them yourself and keep that income in your practice? Why would you send that out? I mean, I talk to some dentists that say, I send out maybe 100 cases a year. You're sending out 100 cases a year at 6,500 cases. You're giving an orthodontist friend of yours $650,000 worth of business. And what's he giving you in return? A bottle at Christmas time? A free lunch? I mean, it's crazy. There's no way. Now, I still want you to send the tough case to your friendly orthodontist. Let him do the tough cases, but don't let him do the easy cases. That's what general dentists are for. Easy cases, specialists for tough cases. That's the game. Okay. So improve. This is all the things that happen when you improve behavior, better in school, eliminate nocturnal enuresis, wetting beds, all kinds of things. So anyway, the main thing is you need, if you want to fix them, you've got to get rid of the tonsils and adenoids and expand the arch. Not just one, both. Okay. So we're just talking about, so look at that little, I'm going to show her in a minute. What do you think of that one? That's my favorite case in the world. There she is with buck teeth on the left at age 10. And here she is as a model with her smile on the right. And it was Jeff's and Andrew's appliance, Amara, M-A-R-A, which moved her jaw forward about 8 millimeters and gave her the broad smile with that Hyrex screw we showed you. And that's what she looks like. I mean, when you come in looking like this and you go out looking like a model, you know, I know I changed her life. There's no question I changed her life. And the mother's so appreciative. They gave us Christmas cards almost every year. Okay, you're going to enjoy more going to the office when you do this. You're going to add new procedures. You're going to add new income. Okay, so let's go. And you get a certificate at the end of the course. I went to Poland. They gave me a certificate. This guy's the happiest guy ever to get a certificate. So when you do the course, you have to do 12 lab exercises, put brackets on, trace x-rays, examine temporomandibular joints, on and on and on. And you have to pass 4 tests. You pass 4 tests, do 12 exercises, you get the certificate, 142 hours of CE credits, which will last you for many years. We also do in-office courses. We have a course going on in Chicago and Houston, where you can go and learn. It's called a mini residency, where you can learn hands-on in the course and get lectures from one of my instructors. And then you work on other guys' patients. You make your mistakes on their patients. The program is 2 years long. Every 2 months you meet and you treat patients. Live, hands-on, you learn everything. You do everything. And that's how you learn. This guy had to take it twice. He liked it so much. He started so many new cases. He said, I need help with the ones I've got going now. If I need to take it twice. So he was fantastic. Anyway, that's what we do. And this guy in Toronto puts his own course on. Now, he was the guy that gave me the idea 5 years ago. Okay. What are you going to do with her when she's got a headache at age 8? First of all, will she tell you she's got a headache? No, she won't, right? Not going to tell you she's got a headache. She's coming in to get her teeth fixed. So we had her fill out a form, and she admitted she had headaches. So she got a retrognathic mandible. When I see a little girl with a retrognathic, underdeveloped lower jaw with a headache, I get excited because I can tell you 98% of the time I can fix her within a week with a functional appliance I'm going to show you. Every time. Every time. It just works every time. It's ridiculous. All they have to do is wear the appliance. Overjet is 6, overbite of 5. Class 2 molar. Look, the mother says that she brings her home from school due to headaches. Like, imagine if that was your daughter, 8 years old, going home almost every day with a headache. I mean, what's her school going to be like? She's going to fail her school. She's not going to enjoy seeing her friends when she's got a headache all the time, and it affects her whole life. And who's going to fix her? Can a chiropractor fix her? Can a chiropractor move her jaw forward? Can a medical doctor fix her with drugs? I think not. It's only you or me. We're the only ones that can fix her. So you need 5 stars help, but you can do it. So I'll just show you. There's the appliance. Now, I know that looks bulky, but it's not. It's 2 blocks called the twin block that interlock at 70 degrees. And it just goes on the lower block, goes on the lower teeth, the upper block, and the upper teeth. And see how they interlock just behind the second primary molar there? There's a 70-degree angle there. And you can see where the lower jaw can't go back. Okay. And so you put that in, you get a special design from Jeff and Andrew. She wants a color, you give it to her. We'll show you the design of the appliance when you come in and take the course. And the jaw moves forward like that. Within 7 months, the jaw's forward. Now all you have to do is maybe put composite buildups on the primary molars. I'll show you another case. And wait till the permanent teeth come in. That's it. That's what she looks like. I mean, 7 months. 7 months. The jaw moves forward. Some of these kids have TMJ problems. Well, she's got headaches. That's the main problem. The main symptom of TMJ is a headache. So we brought her jaw forward and she's okay. And then we put brace on and finished her. But look at that nice profile change. But look at that. I mean, that's why you want to go to the office every day. You look at that little girl who's 8 years old with headaches, and you look at the girl on the right, it's the same girl at 9 years old, no headaches, grinning from ear to ear, not losing time from school, happy, 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 and you changed her life. You changed her life. You changed her from headaches to no headaches, and you made her look more beautiful from the front and the side. You made her healthier. I used to think when I did that, I was doing it because they look better. But you know what's interesting? When you make them look better, you make them healthier. When I expanded their arches to make them look better, I made them healthier. When I brought the jaw forward to make them look better, I made them healthier. So it's kind of neat. The functional appliances are such a vital part of dentist training that I'm hoping you're all going to sign up for our course in Chicago and Dallas. Now, we also have the course online. And so if you want to sit home and watch it and pass the tests and do things, you can do it. But sometimes it's easier to come to the course to learn how to bend a wire and do stuff. But we have people that take the course online and they still start cases. Lee tells me that some of them start more cases on the online course they do in the live course. I can't believe that, but that's what she's telling me. I have to believe Lee. There's video games. Okay, show you 2 more quick cases. Okay. Here's a case with an anterior open bite. Okay. He's got a tongue thrust. What do you suppose is causing that? Many, many times it's the tonsils. The tongue's coming forward to open up the airway so the patient can breathe. So the first thing you have to do is get the tonsils out. The next thing you have to do is expand the arch and put a crib on there. Okay, so let's show you the appliance. I know, and there's the tonsils. You got to get those out. Okay, number 1 step, get the tonsils out. Those got to come out, especially the one on the right-hand side there in the photo. That's a big tonsil. That's got to come out. Remember, I'm pushing the tongue down with a mirror. You don't push that tongue down. She's got no airway. Okay, so let's get the tonsils out. And there's the appliance they make for you at 5-star. It's an upper Hyrex with a tongue crib. Okay, I know that looks like a medieval appliance, but it works. And there's all kinds of functional appliances you can get too that are removable to try and solve that problem. We find most times you got to put something fixed in there that doesn't come out, and that'll solve tongue thrusting problems or thumb sucking problems. Again, bands on the molars, mesial rests on the primary molars. You got that great big tongue crib on there. You need to leave that in for 5 months. Tongue crib comes off in 5 months and you'll see it works. 1 month, the open bite went from 3 millimeters to 1. That's how fast it goes. And it just works. You leave it in for 5 months, you take it out, the habit's solved, no more tongue thrust, no more open bite. I mean, if you don't fix it now, the tongue goes in between the teeth 2,000 times a day. She's going to have an open bite for years and years and years. The best time to do it is when they're 8. Why wait till they're 13 to put that appliance in? They wouldn't like it. Adults don't like it. So fix the kids and they won't have problems. But remember, you can see the tongue thrust on the left sticking between the teeth. And on the right, it's gone. So leave that on for 5 months and take it off. We expanded only 4 millimeters. And that was phase 1. So you want to do phase 1 and then let all the permanent teeth erupt. And then you think about braces or aligners for phase 2. So we charged them for phase 1 only and then wait till all the teeth erupt. And then she was done there. Very easy to do. I mean, what did I do? I just wrote the letter to the ear, nose, and throat specialist and asked him to take the tonsils out, which he did, because this child was choking at night and all kinds of problems. And maybe she was hyperactive. I can't remember. And they did it, and now she looks great. Charge her $2,000 for that appliance, and records are $500. I want to make sure you understand that you shouldn't start this tomorrow. You need, even though you probably could, I want you to take full records. Our records, our chart is 12 pages long. It's unbelievably comprehensive. You take comprehensive records, you won't make the wrong diagnosis. You'll have great results because you only treat the easy cases. Now, I thought I'd get a better smile out of that. I mean, I did a good job. She should give me a better smile, but she's got to learn how to smile. If you've been covering up her smile so long, she's not smiling. Okay, so let me show you the last case. Okay. Again, how do you diagnose headaches? You have to give them some form to fill out to show that they've got a headache. So here's the one I like the best, called the TMJ Health Questionnaire form. First question is, do you get headaches? Yes. You get headaches in the front and the back? Yes. Ring in the ears? Yes. Deep overbite? Yes. Okay. So you give everybody that chart, and Lee would send that to you. If you contact Lee at rondoseminars.com, she will send you that TMJ Health Questionnaire form and give that to every single patient that comes to you for the rest of your life. And tell them we're trying to screen patients for temporomandibular joint problems. Now, let's say you don't want to treat those patients. Find out someone in your area that does it. You can call Lee. We can find a dentist in your area that's treating TMD. We know lots of them. Okay, in Chicago or Dallas or wherever you are in Chicago, wherever you are, we'll try to find a dentist. I've been teaching for 35 years. You know, Jeff and I used to have dark hair, and now we don't. So I just tell everybody we're wiser, Jeff, than we used to be, because with age comes wisdom, and with age comes gray hair. So don't worry about it, Jeff. You look fine. Don't dye your hair. Okay. So I want to make this comment. Any female over age 20 that has a deep overbite, there's about an 80% chance you've got TMD problem, TMJ, temporomandibular joint dysfunction, TMD. So she's got headaches, a deep overbite, and she's coming to me with headaches and a malocclusion, right? She's got a malocclusion, got a deep overbite. So how do we do it? Okay, we want to move the condyle down and forward, but she has no overjet. So you can't move the condyle down and forward. There's only one way you can do it. You can build up the vertical, increase the vertical, and move the condyle. So when you do buildups on the primary molars, which I'm going to show you, you move the condyle down and forward. Now, you need a cephalometric film. Legally, you cannot start an orthodontic case, even phase 1, without a ceph. You can do it, but if that patient transfers to another area and they ask for your records and you don't have a ceph, you're putting yourself at risk. So don't put yourself at risk. Learn how to take a ceph. 5-star will trace it for you. So we teach you how to trace some cephs in the course, but after that, all cephs go to the 5-star, and you learn all these numbers, and you talk to the patient about these numbers, and they're most impressed. They think you're really smart because you know all those numbers, but those numbers tell you exactly what's going on with the patient. So you need to diagnose all cases like this. Now, this is not diagnosed correctly. Functional problem, she's got TMD. It's not normal. I should have put TMD under functional. She's a skeletal class 1, which means the maxilla and the mandible are even. If she's class 2, that means the mandible is back. If she's class 3, that means the mandible is forward. But she's class 1. Okay? And she's class 1 dental. All she's got is a deep overbite in some spaces. Easy case. Okay? The treatment plan is to put a ricinator in the upper. Okay, so we talk about this appliance. It's fantastic appliance. You put bands in the molars, you put separators in first to make space so the molar will fit. And then you buy this kit from 5-star. That's a McKenzie gauge developed by Bobby Middle's daughter, who was an engineer who decided to help him and help herself and design this fantastic device for taking bite registrations for ricinators, twin blocks, snoring appliances, splints, everything you got in your office. So it's a fantastic device. So you definitely want to get one of those when you take the course. Now what we do is we put the jaw 1 millimeter overjet, 1 millimeter overbite, and then inject polyvinyl siloxane in the side. Put polyvinyl siloxane in the side and send the upper scan, the lower scan, or upper model, lower model, plus the bite registration to 5-star, and they will send you back miraculously a proper Ricinator to prevent the patient from biting on the roof of her mouth. So you can see she bites on the plastic up here. She doesn't bite in the roof of her mouth. So everything's great. Now, the only problem is the back teeth don't touch. But it's not really a problem because the headaches are gone. It's not really a problem because the overbite's gone. So all you have to do is you have to bring the posterior teeth up. So we do composite buildups on the first and second primary molar. And in the course, we show you the technique for that, which is really easy. Okay. We don't cover the lower first molar. We want it to erupt. We're establishing a new occlusal plane. No more deep overbite, no more headache, new occlusal plane. Okay. And you don't take those buildups off. You want the first primary molar to come out and the first bicuspid to erupt to that level. You want the second primary molar to come out, second bicuspid to erupt. You want the first molar to come up on its own. New occlusal plane, headache's gone. Headache's gone within a day. I mean, it's ridiculous. Within a day, headaches are gone because you move the condyle down and forward away from the nerves and blood vessels. No big deal. I mean, you got to know the anatomy of the temporomandibular joint and know that functional appliances help fix the problem, prevent the problem. So when the condyles move down and forward with the Ricinator and with the buildups, patient's perfect, no pain. Condyle moves from the one on the left to the one on the right with the buildups. Now, I've been taking x-rays of the temporomandibular joint for 25 years. So I know I take an x-ray before, it looks like the one on the left. I take an x-ray afterwards, it looks one on the right. So I know the condyle is moving. And we do show that in the course, but you don't need x-rays of the temporomandibular joint to treat these patients. All you have to do is use functional appliances for the right cases, and you'll get these results. And believe me, when you help their headaches, you're going to feel a lot better. Because who else can do it? You're it. You're it. Okay. So there's the case. So you have to put the buildups on so they can chew. You have to put the buildups on to help the temporomandibular joint. And if you want to speed things up a little bit, put an elastic on. Put a bracket on the lower first molar and run a vertical elastic to the Ricinator in the upper. And pretty soon, now remember, the jaw can't go back because they get the ramp there. Jaw can't go back and she can't bite in the roof of her mouth because she hits the plastic on the Ricinator. So look at the difference now. Look at the photo on the right. The molars come right up. Now the buildups have worn down a little bit, but that's okay. She still has a normal overbite and all her teeth are touching now, so she can chew. See, look at the photo on the left, the big space, and look at the photo on the right. The molar came up, had a little help with that elastic. Charged $2,500 and records $500. I mean, all I did was to take impressions for a Ricinator. The lab did the work, they made it, cemented it in, and did 4 buildups. That's $2,500. And the mother is so happy. She got rid of headaches. We certainly could have charged more. Now, if you do that, phase 1, and they need braces, where do you think they're going? They're not going to anybody but you. You tell them we do braces if you need them. We do aligners if you need them. We'll see you every 6 months. You come back, no charge for the consultation. We'll just observe you and see what you need. If you need braces, aligners, we'll do them for you. Okay? And we'll be reasonable because we've done a lot of the work in phase 1. And because phase 1 was successful, they want you and they want to come back to you. They're going nowhere else. Okay, we're almost done here. So we told you the Ricinator works. Remember, 80% of females over age 20 have headaches, big time. So you want to fix her now, so she'll never have headaches. Lots of times when the mother has headaches, you say, look, do you want to end up like your daughter or do you want me to fix it? She says, just fix it. Here's my checkbook. Have a nice time. So there's a Rickinator in the book. And I think that's probably all there is. It's now 4 minutes after 8, or yeah, sorry, I'm 4 minutes late. I went overtime. I tried my best to do exactly an hour, but of course, Jeff took up too much time introducing me. So anyway, so now I just want to say that I hope that you enjoyed the presentation. I would recommend something. I would recommend that you take this video, because you're going to get a copy, and have a staff meeting. Tell your team that you're going to have an hour and a half meeting. You want to show them something new, something different, and tell them that you want to pursue this in your practice, but you'd like to have their cooperation and their support, and show it to them and say, look, this will help your own kids. It's going to help all the kids in our practice. It's going to focus on our practice being a health-oriented practice as well as a restorative practice. You can have both. And then see what they say. So you pay for lunch, but you don't pay them an hourly wage. And they get a CE credit from Rondo Seminars for an hour and a half. So they want those, okay? And then go around the room, ask individually what they both thought, and watch the reaction. If you get a positive reaction, great. If you get a negative reaction, you may want to consider the length of employment that employee wants, because she's not going to back you up and you're really interested in doing this. You really need them on board. You need your staff on board. You need their help. So that's my advice to you. Okay. Next, we've got Andrew, who's going to answer is going to pose some of your questions. Andrew, my boy, you're on.
Hello. Thank you, Brock. That was a great lecture. I hope everyone enjoyed it. It's really amazing to see the kind of difference that you can make in patients' lives. So I hope you guys enjoyed that. We do have a few questions. So first question, what is the youngest patient you can treat, and how do you know if they are too young?
Okay, well, first of all, you want a good cooperator. You can, when you're doing the records on the patient, when you're taking the scans, when you're doing the x-rays, when you're doing the photos, you can see if those kids are well-behaved or not well-behaved. And if they're well-behaved, you can put a fixed appliance in as young as a 5-year-old. But I prefer probably 7, 8, 9, because they're a little bit older, they're a little easier to motivate, and they understand what's going on. And I'd like the first year molars in, the 6-year molars come in, because then you can use your appliance and attach to those molars. So I prefer maybe 7, 8, 9, but I can start them as early as 5 if they'll cooperate. But
Great.
Okay, go ahead.
Yep. Next question. Can you expand adults?
So I should ask you that question. How many thousand appliances have you made for teenagers and adults that passed their growth spurt? I mean,
Yeah,
lots, right?
Yeah, we make expanders for adults all the time. So really it's just you have to go slow. You can't go fast like you can on a little kid. We always recommend doing slower expansion.
Yes.
Feel like it gets more stable results for sure, rather than doing rapid palatal expansion. But yes, we make expanders for adults all the time.
So that's the best answer, right? I mean, I've made hundreds, he's made thousands. Well, I probably made thousands too, because I've been doing this for 35 years. And I used to go to 7 different offices doing ortho. I loved it so much. I worked with a retail dental group and I did all their offices and I loved it. But then finally my staff said to me, why are we doing this? Why don't we just build London? And of course, now we've got 7 ops going. We've got 2 consultation rooms and we're booked solid. And we're just so busy and we're so happy because we're having so much fun with the patients. I joke when I say I was never thanked for a filling. I never put a filling in anybody's tooth that I was thanked. Because after I gave him the filling, I gave him a bill. And before I gave him the filling, I gave him a needle. But with ortho, I get thanked daily. Every day they say, thank you. You saved my marriage. You got rid of my headaches. You gave my child self-esteem. She got a beautiful smile. We were told extractions by 2 or 3 people. You didn't do any extractions. I mean, they just thank you, and I'm sure and it must be good for you working in an industry where, yes, you're making some money making appliances, but all the people you're helping, you know that without those appliances, we can't produce. How much is your Schwartz appliance?
Yeah, so a Schwartz, well, actually, in general, expanders are generally anywhere from 125 to 225, roughly. A Schwartz appliance is about 125.
And we're charging 2,500.
Pretty sweet
Well,
deal,
I tell
huh?
everybody at the course, you should raise your fees. And everybody at the course says, no, 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 don't let him raise his fees. I said, yes, you raise your fees. You should, because we're getting a lot of money for these cases. But you're able to keep your fees reasonable, and we like your lab very much. How many employees do you have?
Oh gosh, I think we have in between 45 and 50 employees.
Yeah, I mean, that's good.
Mhm.
That's good. I mean, that's a good size lab, and you're exclusively ortho, right?
Yeah, well,
And
only
and
ortho.
aligners.
Yeah, we do ortho, aligners, a few sleep apnea appliances, and then night guards and orthotics and splints for TMD too.
Right. So that's good. You
Mhm.
specialize in the things I do,
Right.
ortho, TMD, and sleep. And so therefore you're very knowledgeable, and you're right up to date on everything. And they will get to know you really well, because they'll be phoning you to get help with where do you put the screws, where do you put the class, what all about the appliances, and you'll be, and what color, and you'll be a big help to them. And if they run into problems, they can call me or they call you.
Yep, that's what we're here for. So let's I got a couple more questions before we'll wrap it up. Next question, how do you decide between a fixed and a removable appliance?
It's usually the mother that does that. I give the mother knows the child better than I do. So I say to the mother, does your little boy do everything he's told or nothing he's told to do? And the mother says, he doesn't do anything he's told to do. I said, then I'm recommending fixed. Now, we recommend they all get sample appliances of yours. So they have a Schwartz appliance, they got the fixed expander, they got the Rickonator, they got the appliance with the Hyrix screw, and the crib, the
Twin
tongue crib.
block.
I mean,
Yep.
get all those appliances and show the mom. But a lot of mothers like the fixed appliances, and I'm probably about 70% fixed now, because I just don't want to have a problem with them losing the appliance or breaking it. But a little girl of 8 years old would never break it and never lose it. So it's case selection. Some others will say, well, look, he plays a lot of sports, so I'd like to have removable ones so he can put in his night guard or mouth guard at night for sports. And that's okay. So there's lots of reasons, but usually the mother is the one that decides whether the child's cooperative or not. If they're playing a lot of sports, it might be removable.
All right. Looks like we got one more question. How do you decide whether to use a twin block or a Rickonator?
Oh, that's a good question. So a Rickonator is for overjets 3 millimeters or less and deep overbites. Okay, so if you got a slight overjet, just a little bit of an overjet, you can use a Rickonator and use it to correct the deep overbite and a slight overjet. But if the overjet is 4 millimeters or more, you need a twin block. So we cover this really well in the course, and of course you know all these things too. But these appliances work so well. I mean, your lab is exclusively making these appliances. Obviously, you have a lot of clients. You have a lot of successful clients. I love it when I hear an orthodontic person, an orthodontic clinician, say, these appliances don't work. And I said, well, that's interesting. I know a lab in Texas that has 45 employees making appliances that don't work. And they've been in business for 25 years. I'm wondering how they get possibly in business making these appliances that don't work. I mean, they must be crazy. They must be losing their shirt. So it makes no sense. You wouldn't keep doing it. I wouldn't be doing it if it didn't work. I mean, I do what works. You do what works. Mm-hmm. We can always get better. We can always design new appliances. And you and I and Bobby, your your other partner that couldn't make it tonight. We worked on the design of many appliances together. And we just are always trying to improve things. And so that's what's kind of fun. So I'm going to talk about tongue tie next time, which you've never heard me talk about, because I got this hygienist in my office that's been teaching us. So it's phenomenal and that'll be in session 2. Okay, the next session, we're going to talk about how to correct class 3s, real simple class 3s to avoid surgery. And we're going to talk a little bit about airways and tongue ties. And I think I've got some other case to show you. So it'll be fun. So hopefully we're going to do that in about a month. So let everybody know that stay session 2 for free too. It's amazing how many people sign up for free. If I don't charge, everybody takes the course. I'm sure that's why I should run the course with no charge, and then everybody would show up and we'd have a great time. Anyway, so that's the question. That's all the questions. That's good.
Yep, that was the last one. I think Lee was going to close it out.
No, Jeff wants to close.
Jeff, no, that's right. Jeff is going to.
Hey, Brock, great job as always. Good to see you. And Andrew, same with you. Want to obviously thank Brock for taking the time away from his life and practice to do this for us, and for Andrew to show up and help out as well. And also for Lee, I know she did a lot of hard work behind the scenes to get this thing up and running. And for the attendees, I'm sure you enjoyed it. I hope you did. For those of you that we're already working with, we thank you for the trust you put in us. And for those of you that are just getting started and are looking forward to doing ortho, we look forward to earning your trust as well. So thank you guys for sharing the night with us, and we'll see you in about a month.
Thanks, Jeff. Thank you, everybody, for attending. We really appreciate the time you spent with us. And I'm hopeful that I can help any of you become more fulfilled in your practice and help more kids with their problems. So thanks again for showing up, and thank you, Jeff, and thank you, Andrew. It's always a pleasure to work with you, and I hope we get another 15 years out of it.
Let's hope so.
Absolutely. Likewise.
Okay.
Good night,
I want
guys.
to keep
and
working
happy Easter.
till you get gray, when you get a gray beard. Like
It's
as
a
soon as
little
he
bit
gets,
going on
soon as he
there,
gets gray beard, I'm out.
You know, I
Okay.
looked all over the house for a black wig I was going to put on, and I couldn't find one. So.
Okay, thanks, everybody.
Good
I
night,
guess Lee
guys.
does Lee want to say goodnight? Do you want to say goodnight, Lee? She's guessed she could.
Yeah.
They should see do they know what you look like, Lee?
Well, actually, I'm just trying to do that right now, but at least I can say goodnight. If you can't actually see me, it helps to turn the thing on. So thank you, everybody, for coming. And just reach out to me at Lee at Rondo Seminars. I'm always available. I love answering questions. I love talking to everybody that I meet through this. It's always fantastic. And just like I said, I will be following up with everybody as well by email. So thank you again for all coming.
Good night, everybody.
Hi, guys.
All right. Good night. Thanks.